Hello, you twos. Welcome to GIT Physiology. My name is Hanyi. You guys probably have seen me around PSPupper a couple of times last year. But basically, I will be taking you through the entirety of GIT Physiology, hopefully in one condensed video. Don't know how condensed this will be. Basically, we will split this up into two sections. First, talking more about like the gut side of stuff, and then later on talking about the liver side of stuff. So for this first section, mostly this will be about like gut motility, secretions, and then a bit about the liver function test and jaundice, as well as hepatitis in the second half. There will be a ton of questions, which I won't run you guys through. They will all be included in the slides though. And if you have any questions, we'll be doing a bit of a Q&A session at the end of the entire GIT unit. So if you have any questions from that, either keep them until then, or feel free to message any of us or chuck them on Curious Cat. Anyways, let's get started. So basically the gut, we've got four primary functions. First of all, nutrition. Everyone knows you need to eat, and yeah, your gut is responsible for basically absorbing all of these nutrients. Then we've got excretion. Everything you eat gets defecated. Well, most stuff you eat gets defecated. Then your GIT also controls your fluid and electrolyte balance. It also provides immunity, because if you think your gastrointestinal tract is pretty much a direct connection to the outside world. So if you don't have the defense mechanisms necessary, you are going to be getting very sick. So these are the four primary functions of the gut. Pretty straightforward. Continuing on. So basically, in terms of sphincters, we've got 7 sphincters in total, starting from the top, going to the bottom. You've got your upper esophageal over here. That controls if you're going to be swallowing stuff. Then lower esophageal, which is between the junction of the esophagus and the stomach. Then between the stomach and the duodenum, we've got the pyloric sphincter. Then continuing on, inside the duodenum, you've got something called the sphincter of Oddi. And this sphincter basically controls the secretion of pancreatic juices from the pancreas into the duodenum. Also controls the release of bile, which we'll talk about later on as well. But basically know that this sphincter of Oddi, it's part of the second part of the duodenum, and it also marks essentially like your foregut and your midgut area as well, which is more anatomy, but yeah. Next up, if we continue down, traveling down the small intestines, you've got then your ileocecal valve between the ileus and your colon. And then continuing through at the end, we've got your internal anal sphincter and your external anal sphincter. So out of all of these sphincters, the top and the bottom, these are the ones that are controlled by somatic innervation. So you control when you are going to be swallowing your food, and you control when you go and take a shit. Everything else essentially is autonomically controlled, and it's all smooth muscle, because you don't obviously control when your stomach is passing food to your small intestines, etc. Okay, so nerves innervating the gut. So we'll talk about kind of 4 in general. The main ones you need to know are enteric and autonomic. But in terms of big picture, so we've got sensory nerves that obviously send signals to the general, to the GIT as well as your brain. So these include your chemoreceptors and your mechanoreceptors. So chemoreceptors, they sense the changes in pH. More so, think in the stomach, if you've got a highly acidic chyme, and that later on goes into your duodenum, that's going to send off signals, because if you have that acid in your duodenum, it's going to burn through and not be fun. You've also got your mechanoreceptors as well. So these are going to sense your stretch. And we'll talk more about these in the next slide. Then later on, in terms of muscle or motor action, you've got your somatic nerves. These are the ones controlling skeletal muscle. You've got your autonomic nerves. These are the ones that are found in the brain that control glands and smooth muscle. And your enteric nerves, these are the same ones, essentially similar actions as your autonomic nerves, except these are found in the GIT. In terms of what your sensory and autonomic nerves do, so sensory nerves obviously detect stuff and then send the signal to your CNS. Then your parasympathetic and sympathetic nerves, these are the autonomic ones. They are going to be controlling your gut motility and your gut secretions. So if you think parasympathetic, that is your rest and digest. That is going to stimulate your gut motility and secretions via your acetylcholine and also your muscarinic receptors. And then your sympathetic, that's your fight or flight. So it's going to decrease that gut movement, and that's through your noradrenaline and then your adrenergic receptors. So what about your enteric nervous system? So enteric nervous system, it's also known as a gut brain. The reasoning for that is because it can function completely independently from your central and autonomic system. And for your enteric nervous system, we've got 2 main plexuses. So first is your myenteric, second is your submucosal. So your myenteric ones control the muscle movement. So it controls gut motility and also controls the relaxation or constriction of your sphincters. So myenteric plexus, it's located between the circular and longitudinal muscles. As you can see here, circular smooth muscle is the one on the inside. It controls the size of your lumen. So if it contracts, it's going to decrease the size. If it relaxes, increase the size. Longitudinal, meanwhile, is the one on the outside, and it basically shortens or lengthens the gut by contracting longitudinally. So myenteric plexus, M for muscle movement, or I guess like motility, controls gut motility. So next up, we've got the submucosal plexus located in the submucosal layer, kind of straightforward there. And these control your gut secretions. So a good way of remembering: S, secretions, M, motility. And basically the secretions is what's going to basically help not make you constipated, pretty much. Yeah, so basically also a special note on sphincters. So all your sphincters are constantly constricted. And it's basically through your parasympathetics that causes sphincters to open, and then sympathetics will just cause it to close. Hopefully that's kind of straightforward, but this is a bit of a summary diagram. So we'll quickly run through this. Imagine you have a bolus kind of moving through the GIT. So first thing, your stretch receptors in the epithelium are going to say, okay, we are sensing some stretch. That's going to then send signals to both the central nervous system, so basically to your brain, as well as signals to the GIT. So if we go and look at the central nervous system, that will decrease sympathetic activity and then increase parasympathetic activity because you are like resting and digesting. What that will do, that will increase both your motility as well as your secretions. So parasympathetic, essentially like central nervous system, does both. And then the stretch receptors are also sending signals to your enteric nervous system inside the GIT. The myenteric plexus is going to be upregulated or like activated, and that will increase motility. And then your submucosal plexus in the submucosa will also be activated, and that will cause gut secretions. And overall, all of this will aid with the digestion of food. So this is a bit of a summary slide on that. Just in terms of sphincters, myenteric ones are going to control the sphincters. Submucosal have absolutely no effect on sphincters. Make sure you do know this table. This is pretty high yield with regards to kind of like myenteric and submucosal plexus. So yeah, learn this table. Alrighty, so talked a bit about motility in general. So now we're going to talk about motility first in the small intestine, then in the large intestine. So basically, small intestine, we've got two kinds of contractions happening. First is your mixing or segmenting contractions. These are the ones that actually break up your food and chop it up into small pieces so it then can get absorbed pretty much. The way we got taught it is like 2 steps forward, 1 step back. If you look at the diagram on the top right, kind of contracts in the middle, and then that splits the food here and then contracts over here and then splits it up. So basically breaking down your food into small pieces such that it can be absorbed. And then once all your food has been absorbed, obviously we don't want it in the small intestines anymore. We want to move all of this to the large intestine. And this is where your migrating myoelectric complex comes along. So yeah, when majority of nutrients have been absorbed, everything goes and moves to the large intestine, and it's triggered by either an increase in chyme pH or an increase in the motilin concentration. So increase in chyme pH is basically because in your duodenum, or like small intestines, I guess, you get a bunch of alkaline secretions being pumped out. So if your food has been in the small intestines for quite a bit, your pH will have gradually increased compared to when it first all came out of the stomach. So an increase in pH means food's already been there for a while, probably digested, let's move it along. Motilin is just basically something that is inhibited when a meal fills the stomach. So by the time like all that food has emptied out of the stomach and gone into the small intestine, you would have had an increase in the concentration of motilin, and hence that would trigger that migrating myoelectric complex. So very, very buzzwordy. Make sure you do know mixing, segmenting contractions, and migrating myoelectric complex. These two belong to the small intestine. The reasoning why I say that is because motility in the large intestines basically are exactly the same thing as in the small intestine, just different words. So the kind of segmenting stuff in the large intestine is called Horstrom contractions. Reason for that is because these little blobs essentially are called your haustra, and they are present inside your colon pretty much. so same situation as before. During the process of horstrom contractions, this is when all the water and electrolytes is being absorbed from the fecal matter. Otherwise, you just have like a lot of diarrhea. And once that has all happened, then we want to move all of this fecal matter essentially towards the sigmoid colon, towards the rectum, in order for defecation to then take place. So that's then called a mass movement. And what happens is all the tenei coli, which you guys should know from anatomy, that simultaneously contracts. And at that point in time, all of the haustra, so these blobs, then disappear, because if you imagine, I guess like elastic in a sense, if you pull it all of those blobs are then going to like basically lengthen out. So during the process of a mass movement happening, you are expected to see absolutely no haustra. Yeah, pretty much, and that causes everything to move towards the rectum. And just know this is basically stimulated when you have stomach distension. So the idea is if you are having a meal, your body's like, oh, well, we need room for this additional food. So that's going to trigger a mass movement. And so when you get rid of all of the fecal matter, you then have like space for that food to come in and become digested. All right, so up until this point, all of the fecal matter is now like come down towards the sigmoid colon, towards the rectum, ready to be defecated. And so defecation reflex, what happens is you've got a bunch of stretch receptors in the rectum. They send a signal up to the spinal cord, and you've got parasympathetic nerves, then relaxing the internal anal sphincter, and then your stools move to the anal passage. At that point in time, you then make an active decision. Am I in a position where I can actually take a shit, or am I not? So if you decide, yes, I can go to the bathroom, then you cause the relaxation of your external anal sphincter, which then causes you to basically take a poo. If you are not in an area where I guess a bathroom is readily available, there's something called retrograde peristalsis that occurs. And what happens is essentially you decide, okay, we can't go to the bathroom. So cerebral cortex inhibits the reflex, and then you get constriction of your external anal sphincter. And what happens is the stools kind of go backwards. So they start off at the anal canal, return back to the rectum, and return back to the sigmoid colon. So basically retrograde meaning backwards, peristalsis is like that movement. So yeah, basically all your fecal matter goes back up. So a couple of abnormalities to kind of know about. First, constipation, when you like don't have enough either like fiber or perhaps like excretions in order for your stools to kind of pass through. Yeah, so either poor motility or some kind of obstruction. And to treat that, kind of like treat the underlying cause as well. So if they're not drinking enough water, not getting enough fiber, definitely changes in diet would help with that. But if it's severe, then laxatives are the way to go. We'll go through laxatives a bit more when we talk about pharmacology. But constipation, that's pretty much what you do. For diarrhea, it's opposite side of the spectrum. So you have too much like water or like fluid in your stools. In that case, main thing, symptomatic treatment, and also fluid and electrolyte replacement. And the important bit of that is because if you basically have diarrhea, you're losing a lot of electrolytes. Those electrolytes can include your sodium and potassium. And as you know, sodium and potassium are very important when we talk about the heart. So that can cause arrhythmias and serious problems with the cardiovascular system. So you don't want that happening. So give them fluid and electrolyte. Last one, Hirschsprung's disease, not really high yield, but basically congenital disorder where you don't have like nerve cells in your colon. And if you think about what the nerve cells are responsible for, motility and secretions. So if you don't have enough nerve cells, you're going to have difficulty passing the stool. Pretty much what you need to do then is you need to get surgery to basically bypass that affected part of the colon. Kind of a main symptom, you've got a newborn that has failed to have a bowel movement within 48 hours. Once again, not super high yield for you guys, but that's just something interesting to kind of consider, I guess. Okay, so that's all of gut motility. Hopefully that kind of made sense. If not, feel free to like message. But moving on, we've got gut secretions. So once again, kind of starting from the top and then moving down. So we'll start off with saliva, then going to the stomach, then talking a bit about liver secretions and pancreatic secretions. So starting off with mouth and salivation. Got a lot of cute baby photos. Anyway, so in the saliva, you've got a bunch of different things. So you've got your water, which is going to be helping with speech, drug absorption, and taste sensation. We've got mucin, which helps lubricate the food. amylase and or ptyalin. These help with digestion. So amylase, we had a question, I think, in past exams, essentially, where like where digestion first occurs or something. Just know that amylase is present within your saliva. So digestion actually starts in your mouth instead of like, I don't know, somewhere further down in the GIT. You've got immunoglobulins, which basically immune system, yep. And ions, basically calcium phosphate to prevent demineralization of teeth. This stuff isn't too important. Just make sure you know amylase is present in saliva. In terms of salivation, so if we have problems with it, you can have ptyalism, where basically you have too much saliva being produced, in which you give them atropine, which is pretty much a muscarinic antagonist. Would have quizzed you guys on this, but obviously this is a recording, so I can't really do that. And if you think muscarinic antagonist, that's going to go against the parasympathetic nervous system. So that's going to decrease saliva production. And xerostomia is the opposite, where you don't have enough saliva being produced. So you give them a muscarinic agonist to try and, I guess, like enhance the salivation process. In terms of some triggers and some like excitatory and inhibitory triggers, so excitatory ones, if you are thinking of food, if you actually have food, that's going to trigger salivation. Interestingly, with nausea as well, so that's going to trigger salivation. Reason is if you are nauseous, you are more likely to vomit. And if you are vomiting, you're basically emptying your stomach contents. And your stomach contents are very, very acidic. So if that basically comes up, that's going to like burn through like your esophagus and also your mouth. Your body wants to kind of prepare for that. So by pumping out a lot of saliva, that's going to hopefully cancel out a bit of the acid and balance out the pH a little bit. So that's why you get more salivation when you're nauseous. In terms of inhibitory triggers, so sleeping and when you're very scared. So if you're sleeping, you don't really need saliva. And when you're like terrified of something, well, the last thing you are going to be doing is like digesting food. You're in that fight or flight mechanism. Yeah, you're in that kind of zone. So yeah, you won't be having any salivation there either. Okay, so that's basically saliva. Let's talk about the stomach. So stomach, the storage area for food, basically helps churn up food, digest it. Speaking of digestion, we've got pepsin, which is a very important enzyme, or like, yeah, it's basically an enzyme that helps break down protein. Your stomach also secretes intrinsic factor, which is important for the absorption of B12. And B12 is important because it's basically required in your like neurological system. So it's important for like nerves. So if you don't have enough B12, your nerves aren't going to be functioning as well, and you might get like neurological disturbances as a result. And then stomach can also absorb a few fat-soluble substances such as alcohol. But main things you need to know, pepsin and intrinsic factor, which we will talk about now. So basically in your stomach, you have a bunch of gastric glands or gastric pits. And within these pits, you have mainly 4 different kinds of cells. So start off, we've got our mucus cells located on the top. Mucus cells kind of like secrete your mucus, and that's going to provide lubrication and also kind of protect your epithelium from all the acid that is present inside your stomach. Then we've got your parietal cells, which I think it's red here. These secrete your hydrochloric acid as well as intrinsic factor. We'll get into the nitty-gritty of this in just a moment, but know that, parietal cells, hydrochloric acid, and intrinsic factor. Chief cells then secrete your pepsinogen. Pepsinogen is later converted into pepsin, which then breaks down your proteins. And you've got your enteroendocrine cells, and we've got 2 types. You've got your G cells, which secrete gastrin, and your ECL cells, which secrete histamine. And basically, both of these pretty much just enhance acid secretion. Once again, I'll explain this in just a moment, but that's pretty much all you need to know about these. This slide, very, very important. Make sure you know what kind of cells release what. Will definitely be a question on the exam on this. So very high yield, make sure you know this. Okay, so talking a bit about pepsinogen. So I said that pepsin is what breaks down proteins. How does this work? Well, you've got your chief cells, which basically release all of your pepsinogen. Pepsinogen is then activated via a low pH. So basically, this low pH is caused by the hydrochloric acid, which is secreted by parietal cells. And the hydrochloric acid is going to make everything very acidic. So in that acidic environment, pepsinogen then gets converted into pepsin. And pepsin is the activated form that then breaks down your proteins into your peptides, which are then absorbed by I guess, like the GIT. Yeah, so that's pretty much that process. With regards to how hydrochloric acid is actually produced, well, there's kind of two parts to the story. So first, we are going to talk about how do we actually get proton pumps embedded within the lumen. So what happens is like your proton pumps are actually preformed and they exist inside your parietal cell. But obviously, if they're in the middle of the cell, they're not going to be pumping anything anywhere because you'll just be pumping stuff around in the cell. We actually need the protons to go out of the cell into the lumen. So first of all, you need these proton pumps to be embedded inside the membrane, which we'll talk about in just a moment. And the second part is once you have these proton pumps in the membrane, what's the process that allows your hydrogens to be pumped out? And to kind of explain all of this, I will attempt a drawing. Hopefully this will work. Alrighty, so basically, this is pretty much the cell that was on the previous image. Think about this as your parietal cell. I probably should have labeled that, whoops, parietal cell. And in your parietal cell, you've got a bunch of different receptors. So we've got a G receptor here, ECL receptor here, muscarinic receptor, and a somatostatin receptor. So what happens is you pretty much get stimulation of any of these three receptors, or all three at once, doesn't really matter, I guess. And what they might be. So for your G receptor, you might get gastrin coming in. That's going to activate your G receptor. You might get histamine coming in here. That's going to activate your ECL receptor. And muscarinic, remember, is to do with your parasympathetic. So you have acetylcholine come in and activate your muscarinic receptor. Point is, all of these are basically going to activate your secondary messengers. And your secondary messengers is then basically, oh, by the way, just quickly flagging, this is your preformed proton pumps. And basically what your secondary messengers do, that basically causes these preformed proton pumps to basically migrate down towards the membrane, or I guess like the luminal side of the cell. And what happens is that basically comes here and they embed themselves inside the membrane of your cell. So what happens is now you have a bunch of these proton pumps all here ready to pump your protons out into the lumen. Basically when you have actual like hydrogen ions being formed inside the cell. Just also a quick note. So this, and this. So your G and ECL and muscarinic receptors, these are all excitatory. So these will basically activate the secondary receptors, secondary messengers, versus your somatostatin receptor. This is actually inhibitory, and that will basically inhibit the activation of these secondary messengers. So yeah, if you see somatostatin being activated, don't say like you've got secondary messengers causing the migration of your proton pumps. Yeah, so that's pretty much what causes your proton pumps to move into the luminal side of the cell. Next up, we'll talk about, I guess, how hydrochloric acid is actually formed. All right, so drawing number 2. Once again, we've got our parietal cell sitting over here. Luminal side this time is that way instead of the bottom. Basically, this is the lumen and this is the basal side. As for this thing down here, this is basically just a vein that's draining towards, draining away from the stomach. So generally what happens, you've got a bunch of chloride that's in your bloodstream, and what the chloride does, comes along, meets the cell, kind of goes into the cell, and then just kind of passes out, and chloride then gets pumped out into the lumen. So yeah, chloride's kind of straightforward, just kind of comes along, goes in, gets pumped out, and that's how you get the chloride part of hydrochloric acid. The H plus part is a little bit different. So basically you've got aerobic respiration happening inside the cell. So CO2, H2O, that's going to H2CO3. H2CO3 then gets broken up into 2 parts. So then you've got your H plus part, and then you've got your HCO3 part. And H plus part, if we remember from the previous image, which is literally just here, you've got a bunch of proton pumps that are embedded inside the membrane. So your hydrogen ions then basically get pumped through these hydrogen pumps and enter into the lumen, and that's how your HCl is pretty much formed. Whoops, that's meant to have a minus here. So then what happens to your HCO3 minus? Well, that then passes out into the blood. And this is why we say like there's an alkaline tide that passes through. So What that basically means is because you've got a lot of HCO3 minus being formed, that all passes through into the bloodstream. And because this is negatively charged, this is basically going to make it more alkaline, and that's going to increase the pH. So it's important to kind of know that the blood that's leaving the stomach is going to be more alkaline or have a higher pH in comparison to the blood that's entering the stomach area. And the reason it's called alkaline tide, it literally just means it's more alkaline. Sorry, the blood that's leaving the stomach is more alkaline. Yeah, hopefully that makes sense. Now I will just jump back to the original PowerPoint. Alrighty, and we are back. So this is pretty much a bit of a, I guess like a summary, or pretty much just what I drew out before, but a screenshot of that. And yeah, that explains how hydrochloric acid is pretty much produced in the stomach. So in terms of secretion of hydrochloric acid, we've got 3 phases. In the cephalic and gastric phase, you will get an increase in hydrochloric acid secretion. In the intestinal phase, you will get a decrease. It's pretty logical if you think of what's happening in each phase. So cephalic, you're anticipating having food. So it's either the approach of food or the presence of food. And because you're preparing to eat food, that's going to increase the hydrochloric acid secretion. In the gastric phase, you've got your stomach distending. So there actually is food in your stomach that will increase hydrochloric acid secretion. Intestinal phase, you no longer have anything in the stomach, or you have less stuff in the stomach. So you're going to have hydrochloric acid being decreased instead. So a couple of issues that can happen. Very, very important thing for you guys to know, peptic ulcers. So basically refers to like ulcers inside either the stomach or the duodenum. And it's usually caused by like mainly 2 things. It's either like H. pylori or some kind of like NSAID that the patient is taking. So be very aware, especially if someone has been, if someone has something like osteoarthritis or like rheumatoid arthritis, and they're taking a bunch of NSAIDs, and they then come in with burning epigastric pain, you should be thinking, oh, wait, yes, this could be a peptic ulcer. The way that we diagnose it, so you can use the urobreath test. That's basically for H. pylori. And the way we treat it pretty much is antibiotics and with PPIs. So PPIs are your proton pump inhibitors. If we go back to the previous slide, basically we'll just stop these proton pumps from working. You won't get any like hydrogen ions being pumped out, and that's going to stop the gastric acid. Antibiotics pretty much is just for your H. pylori. So a bit about H. pylori, would very, very highly recommend watching Armando's video on this. Just search up like H. pylori. Armando explains it super, super well. But basically, in a nutshell, H. pylori, it's a gram-negative bacteria. And what it does is it secretes something called urease. And it uses this urease to basically burrow down to your epithelial cells. So as you can have a look in this image here, you've got H. pylori here, burrows through the acid, goes through the mucus, and then goes down to the epithelial cells. Then secretes a bunch of exotoxins, which causes your cell to undergo inflammation and your cell to die, which is apoptosis. And basically, this causes more hydrochloric acid to be produced as a result of like the histamines being released. And if you also think about it, if you've lost that mucosal lining, that's going to increase the likelihood of more ulcers being produced because you don't have that protective layer on top of your epithelial cells. That's all of that in a nutshell. If you want to know it in more detail, yeah, check out Armando's video. Would highly recommend. So a couple of other issues, I guess heartburn, GORD is definitely one to know about. Pretty much it's when your lower esophageal sphincter isn't working properly. And so all of this gastric juice basically goes upwards and kind of burns the inside of your esophagus. You will hear this term called Barrett's esophagus. It's basically when you get histological changes in the lining of your esophagus as a result of there being a lot of acid that keeps on like attacking or like refluxing. I don't know if that's a word. Irritating, there we go, the esophagus. And the way we treat that is either through an antacid, H2 receptor antagonist, or a PPI. Antacid will just neutralize the pH, H2 receptor antagonists and PPIs aim to decrease acid. Defective gastric acid secretion, don't worry too much about this, you can read in your own time, not too important. Okay, so we've dealt with the stomach. Moving on now to the liver. So liver does a lot of stuff. You guys will learn a lot about the liver in hematology, but for the sake of GIT, main thing that's important for it in terms of stuff it produces is going to be your bile. So bile, it's important mainly for two things. One, it neutralizes your gastric acid juices. Second, it helps with emulsification of fats. And it does that basically through bile salts and lecithin. So first of all, what exactly bile contains of? So bile, it's basically made up of your cholesterol, and cholesterol is basically then used to produce your bile salts. In addition to that, you've got your lecithin, which together with the bile salts will emulsify your fats. You've also got some electrolytes and also H2O, HCO3 minus, which increases your pH. You've also got your bilirubin as well. So bilirubin pretty much helps with so bilirubin gives the color to the bile and also gives the color to your urine and also your feces. And it is very useful when we are thinking of gallstones, which we'll talk about later on. But in a nutshell, how bilirubin is produced, it starts off by like your red blood cells basically dying, and it's broken down then into your heme and your globin. Globin is then recycled, don't care too much about it. So then your heme is broken down into your iron and biliverdin. Iron, once again, is recycled, don't care about that, at least not now. Let's follow the biliverdin pathway. Biliverdin then becomes bilirubin. So at this point in time, your bilirubin is unconjugated and orange in color. What happens then is the bilirubin travels to the liver, and that's when the conjugation happens. So your bilirubin goes from unconjugated to conjugated bilirubin in the liver. After that, then the conjugated bilirubin goes on to become urobilinogen, and urobilinogen can either go on to become urobilin, which is excreted in the urine, or stercobilin, which is excreted in the feces. So yes, a little bit of like, actually no, we'll go through this later on. That's pretty much how bilirubin is produced. In terms of bile salts, so bile salt synthesis goes in the liver. We start off with cholesterol. Through a series of steps that you don't need to know about, you get the formation of bile salts. One important thing you do need to know is this thing called 7-alpha hydroxylase, and that's pretty much an enzyme that helps, that is like necessary in the production of bile salts. If you have a lot of bile salts being produced, that's going to cause a negative feedback loop where your 7-alpha hydroxylase will be inhibited, and then you're going to have less bile salts being produced. That's all you really need to know for that. In terms of emulsification of fats, so the main thing that does this is your bile salts and lecithin. So bile salts, these weird looking blobs here, basically bind to the outside of your fat globules and prevent these small fat droplets from coalescing and coming back together to form a bigger one. So basically you've got your stomach breaking up all of your food, and then later on, once it enters into the duodenum, they're broken up into little pieces. Your bile salts will go and attach to the outside. Your bile salts and your lecithin will attach to the outside, and then that's going to prevent the fat droplets from coming together. Once you've got these separate little fat droplets, then you've got something called pancreatic lipase and colipase, basically pushing aside the bile salts to access these fatty acids and monoglycerides inside the fat droplets, and that's what causes the digestion of the fat. Yeah, that's pretty much all there is for that. Okay, this slide, this is important. So how do we regulate bile secretion? Pretty much we have two important things that you need to know of, two chemicals. So one is secretin, one is called cholecystokinin. So secretin, when you have a lot of acidic chyme flooding in from the stomach into the duodenum, secretin is going to be released. And what secretin does, it goes to the bile ductal cells and causes a lot of alkaline secretions to be pumped into the duodenum. And the purpose of this is to neutralize or hopefully increase the pH so you don't get eroding of the inside lining of the duodenum. Then your cholecystokinin, this is released in response to fats. So if you have a very fatty meal, then all of this is being released into your duodenum. Your cholecystokinin is then going to cause the release of bile, and it does this via a few different ways. So first of all, it's going to contract the gallbladder. Gallbladder is where all of the bile that was originally made in the liver is stored. So bile basically is made here, travels down these hepatic ducts, and then goes in and stored into the gallbladder until we need to digest fats. Gallbladder then contracts as a result of the cholecystokinin kind of like causing this. And that causes the bile to basically go down and be emptied into the duodenum. Cholecystokinin also relaxes the sphincter of Oddi. And sphincter of Oddi is pretty much the opening to the duodenum from the pancreas and the bile ducts. So if you relax that, all the bile is then going to pretty much come into the duodenum to digest the fats. A couple of other things it does: stimulates production of pancreatic lipase. So lipase breaks down your fats. So if you have a lot of pancreatic lipase being pumped out, that's going to help with the fat situation. Inhibits stomach churning and constricts your pyloric sphincter to prevent more food from coming in. Okay, pancreas then. So that's more liver stuff. Now moving on to the pancreas. Pancreas made up of two parts: endocrine pancreas. Don't really need to know about it now. You will cover it like extensively in the endocrine system. But for the exocrine pancreas, this makes up 85% of the entire pancreas. And there's two main kinds of cells you need to know. You've got your acinar cells, which secrete your pancreatic enzymes, and your ductal cells, which secrete your alkaline pancreatic fluid. So acinar cells, if you have food coming in secreting the pancreatic enzymes, it's going to help with the digestion. Ductal cells deals with the pH issue. So the digestive enzymes that you have that are released, we can kind of classify them in terms of inactive enzymes and your active enzymes. So inactive ones, there's quite a few, everything's like in this table, but the main one you need to know about is trypsin, or trypsin is the activated form. Trypsinogen is what's actually released. And then the active one, you've got your carboxypeptidase, your lipase, and your amylase. So lipase is responsible for digesting fats or lipids, and amylase, like we talked about in the saliva, is what digests your polysaccharides or your carbs. Trypsin and carboxypeptidase, this is for your proteins. So like I mentioned, trypsin is actually the activated form. So originally it's trypsinogen that is released from your pancreas. And how trypsinogen becomes trypsin, it's through something called a membrane-bound enterokinase, or just enterokinase. And that causes trypsin to be activated. Trypsin then activates a bunch of your other inactive enzymes to the active enzymes. An example of that would be your carboxypeptidase and also chymotrypsin. And so if you kind of, talk about it here. Okay. Yes, I'll cover it now. So basically, something to remember is there's a reason as to why a lot of these enzymes are inactivated. And if you look at what, I guess, chymotrypsin and like your carboxypeptidase are responsible for, they are going to be breaking down protein. So if you get the activation of these enzymes too early in the pancreas instead of in the duodenum, you will actually end up digesting your pancreas, which is what causes your acute pancreatitis, which we'll literally get to like in 2 slides time. So pancreatic secretions, pretty much the same deal as with the regulation of bile. So if you have acid, secretin is going to be released from your ductal cells. That's going to increase the pH. And if you have presence of fats in the duodenum, that's going to cause cholecystokinin to be released. And that's going to cause pancreatic enzymes to then be released. And stuff that cholecystokinin does, essentially everything that we talked about before, nothing really new. Okay, so going back to the digestion of, I guess, like your pancreas. So acute pancreatitis is when you have the premature activation of these enzymes inside your pancreas. And the main causes of this, there's a mnemonic called get smashed. And these are pretty much your most common causes. ERCP just refers to a kind of procedure where they stick a scope down, like through your mouth all the way down, to basically retrieve some, either like take a picture and see what's happening near this area of the sphincter of Oddi, or to take out a gallstone. And sometimes that can just cause irritation to the pancreas and cause acute pancreatitis. So the way it often presents, you'll have a severe and constant upper abdominal pain that radiates to the back. So radiating to the back can be quite a few things, like aneurysms, etc. But acute pancreatitis often, look at the history as well. If someone's been drinking a lot of alcohol, has history of gallstones or something, you should be thinking of pancreatitis. In terms of treatment, prompt rapid IV fluid is generally all good. And chronic pancreatitis, this is pretty much when you have pancreatitis going on for a long time, you are going to get defective ductal cells. So that will mean you won't have enough HCO3 being produced. And because you don't have, or because you have a very acidic environment, you're not going to get any of the pancreatic enzymes being activated. So main way it presents, you've got continuous abdo pain, weight loss, and steatorrhea. Steatorrhea, I think, is mostly due to the lack of pancreatic lipase working. So you're unable to digest the fats. So you'll have a lot of fats in your stools. Where you treat it, don't drink any more alcohol, considering like 90% of people with pancreatitis are like excessively drinking alcohol. Give them pain relief and also some pancreatic supplements, given that their pancreatic enzymes do not work. One more, so pancreatic secretion issue number 3 would be cystic fibrosis. Main thing to do with this is like there's a defect in the chloride pumps on the ductal cells, and that can result in defective pancreatic secretion. I think you guys covered this quite a bit in first year, so won't harp on about it, but just something to keep in mind. Yes, and now there's a bunch of questions which I will not run through, but that pretty much covers all the GIT motility and secretion stuff. Now we will be talking a bit about the liver, a bit about gallstones, and how to kind of like differentiate, and also a bit about like liver enzymes as well. Alrighty, so kind of part 2, although this will probably be put together in a single video. But now we will pretty much be talking about the hepatobiliary system. So hepato referring to the liver, biliary, kind of the biliary tree. Yeah, so we'll be talking about liver jaundice, liver enzymes, function tests, a bit about hepatitis, and a little bit about gallstones as well. Sorry. So first up, jaundice, what is it? It's referring to the yellowing of the skin and also the sclera. Sclera is meaning the white aspects of the eyes, and pretty much is caused by excessive bilirubin in this bloodstream. So we can look at it from 3 different perspectives. So breaking it up, first we can consider pre-hepatic, then we will consider intra-hepatic, and then post-hepatic, basically meaning before the liver, at the liver, or post-liver issue. So pre-hepatic jaundice, you guys will recognize this from a previous slide, but if you kind of remember what happens, so you've got your red blood cells breaking down, and then that will end up producing a lot of unconjugated bilirubin, which is then later on produced, later on conjugated inside the liver, and that conjugated bilirubin will then go on to become either your urobilin or your stocobilin, which is kind of secreted or like excreted in either the urine or your feces. So if you have a pre-hepatic jaundice, that's caused by excessive hemolysis of red blood cells. So you've got a lot of red blood cells being essentially killed off, and that will increase the amount of heme that you get, and as a result, increase the amount of unconjugated bilirubin. So if you, I guess we'll talk about the clinical presentation. So the patient will often be jaundiced, and you will have a marked increase in unconjugated bilirubin in the blood. The reason for that is because you've got a lot of unconjugated bilirubin as a result of red blood cell lysis, so much so that the liver can't actually deal with that much unconjugated bilirubin. So you'll have normal amounts of conjugated, maybe a bit more increased, but because it can't handle the excessive supply of unconjugated bilirubin, that's why you'll see an increase in that. The way you'll present, so you'll have normal colored urine and normal stool color. Reasoning for that is because unconjugated bilirubin, it's not actually water soluble, so it will be present in the blood, but it won't show anything in your urine or have any effect on the stool color. And then you've got your intrahepatic jaundice. So this is where you have some kind of liver damage going on, either alcoholic cirrhosis is one, you've got your hepatitis, or just generally some kind of liver disease, and that's going to cause death of your hepatocytes. And remember, hepatocytes are what essentially convert your unconjugated bilirubin into conjugated bilirubin. So if you have your hepatocytes dying, then you are going to get that conjugated bilirubin leaking out. So as a result, you will have an increase in conjugated bilirubin. Unconjugated, maybe not, really depends. If you have really, really bad liver cirrhosis, you won't actually have enough hepatocytes being able to conjugate. the bilirubin, so you might get an increase in the unconjugated as well. But generally speaking, there will be an increase in conjugated bilirubin as a result of intrahepatic jaundice. So findings: jaundice, increase in conjugated bilirubin. You will get dark urine because that conjugated bilirubin is actually water soluble, and you will get normal colored stools. We'll mention pale stools in the next slide, but it's pretty much because that conjugated bilirubin is still able to pass through your bile ducts into the duodenum and give that brown color to your stools. So that's normal. But because you have that extra conjugated bilirubin going into your urine, that's what's causing the dark urine. Liver enzymes we'll talk about in a sec. And then post-hepatic jaundice, this is usually due to some kind of obstruction within the biliary tree that prevents the bile from actually going through and entering into the GIT. So what you essentially get is like a marked increase in conjugated bilirubin in the bloodstream. So you will end up with dark urine because you got that conjugated bilirubin being water soluble, but also pale colored stools. Because if you think normally the bile will be traveling like through your common bile ducts all the way down, entering into the GIT system, then kind of like going through everything and then exiting alongside your fecal matter. But if you don't have that if you don't have that bile actually entering into the GIT because of some obstruction, usually a gallstone, in either the common bile duct or somewhere along that biliary tree, you won't get any of that conjugated bilirubin entering in, and hence you will get pale colored stools because you don't have that coloring. So clinical findings: increased in conjugated bilirubin, dark urine, pale colored stools. This is very, very, very buzzwordy, whether it's like to do with an OSCE, like questions you have to ask in clinicals, or if it's in an exam. Make sure you do know this. Pale colored stools and dark urine is post-hepatic jaundice as a result of obstruction within the biliary tree. Okay, now talking about the liver enzymes. So in terms of liver enzymes, we've got 4 that we may basically look at. So for your liver enzymes, it's your ALT and AST. Biliary, it's your ALP and GGT. So if you have a large increase in ALT and AST, but not a lot of a change in your ALP and GGT, that generally is indicative of an intrahepatic issue. So either some kind of like liver cirrhosis, alcoholic hepatitis, that kind of thing. Versus if you have an increase in ALP and GGT and not much of a change in your ALT and AST, that generally means that it's a biliary issue or some problem inside the bile ducts compared to like the liver. So this is a table. Big thanks to Karan for making all of these, pretty much summarizing the effects of the liver enzymes. So one more thing that we often look at is the ratio between AST and ALT. And if the ratio between AST and ALT is less than 1, that's usually indicative of hepatocellular damage, so paracetamol overdose, viral hepatitis, or toxic hepatitis. If they're equal, it's usually ischemia. If it's greater than 2, alcoholic hepatitis. You can either think about it in 2 ways. So one is like via mnemonic that we got told. It's like stubbies over liver. Stubbies being like you want to drink more than you care about your liver. So that's alcoholic hepatitis. You want to think about this logically. It's because AST has a shorter half-life compared to ALT. So if AST is very, very high, that's indicative of this being an acute issue, so often alcoholic. And if your ALT is very high in comparison to AST, you're thinking a bit more chronic, so something more like a paracetamol overdose, or maybe just the long-term toxic effects of having a lot of paracetamol over a longer period of time. In addition to that, you've got GGT. So if you only have a marked increase in GGT with not much of an effect on AST, ALT, that usually is indicative of excessive alcohol consumption. Not too sure why, but just know if it's just an increase in GGT, that's to do with alcohol. So those were your liver enzymes. Now we're going to actually talk about the tests that measure the liver function. So liver, it makes quite a few different things. So the 4 main things that we look at are albumin, bilirubin, platelets, and INR. So your liver is responsible for making these 3, and INR pretty much measures how fast you can clot. So if we think about there has been an issue with the liver, what you are going to see is you are going to see an increase in bilirubin because so your liver is responsible for making bilirubin, right? Yeah, for conjugating bilirubin. If you have your hepatocytes not working, you will get an increase in the conjugated bilirubin because it's leaking out. Your liver is also responsible for protein synthesis. So if it's not working, you will have a decrease protein synthesis, and that's going to decrease albumin. With regards to INR, so liver normally synthesizes your clotting factors. If it's not doing that properly, it will increase the amount of time it takes for your blood to clot. So that will increase the INR, which is just the pre-recombinant time. And lastly, your liver makes your platelets, so production of thrombopoietin. If you don't have that going on, you'll have a decreased amount of platelets. Yeah, that was the next slide. So this is a bit of a summary that was given to us by Michelle Leach. So if you want kind of everything put together, yeah, this is pretty handy as well. And once again, credits to PS, I Miss Frequent. I think it's like we Miss Frequent now. But yes, these are two very, very good summary tables that we got last year. So if anything, make sure you know these tables. It summarizes it very, very well. So yeah, definitely learn these. Okay, now a bit about hepatitis. So viral hepatitis, they didn't really go through it well in our year. Don't know if they will improve it for you guys, but pretty much viral hepatitis, you've got 5 different types: Hep A, B, C, D, E. Hep A and Hep E, this is via your fecal oral route. A good way to remember this is kind of like A and E. It's kind of like on either side. So like fecal oral route. These are usually acute, not too big of an issue. Hep B, C, and D, meanwhile, these are more your chronic hepatitis. A mnemonic for kind of remembering it, it's quite terrible, but like for Hep A, Hep B, Hep C is like Asia, bitches, cocaine. You get Hep A from traveling in various parts of Asia if you don't get the Hep A vaccine. Hep B is usually from unprotected sex, and Hep C is from your intravenous drug use. Best one to get, A, because it resolves relatively quickly, get a bit of diarrhea, but nothing that lasts too long. Worst one to get, probably Hep C. I'll give it like Hep B as well, because I think there is now a cure for Hep C, but basically Hep C, Hep B, these are both chronic hepatitis. And it can cause quite a lot of damage to the liver. So right now, in terms of vaccines, you've got one for Hep A and Hep B. However, we do not actually have a vaccine available for Hep C. And another additional note is like you can only get Hep D if you get Hep B. So don't be stupid and suggest like Hep D if you don't actually have Hep B. Some other types of hepatitis, not as high yield, but yeah, you've got alcoholic steatohepatitis, non-alcoholic steatohepatitis, or your fatty liver, and autoimmune hepatitis as well. Not that high yield, at least not for second year. You guys can have a look at it in your own time, but yeah, mainly focus on viral hepatitis and make sure that you know this kind of stuff. Okay, and Hep B serology. So for hepatitis B, they will often do a Hep B serology, which is looking at the antigens and the antibodies. So just before we go, so this table summarizes it very well. Before we go through it, just go through 3 definitions. You've got your Hep B surface antigen, and this tells you whether you are currently infected or not. Then we've got your anti-Hep B core antibody, and then also anti just refers to antibody. So you've got your Hep B core antibody and Hep B surface antibody. Amongst these two, your core antibody is the weaker of the two, surface one is stronger, which means if you get a vaccine, it's actually going to cause you to produce your surface antibodies, essentially operating on the assumption that if you have the antibody that's stronger, you won't actually need the one that's weaker. So that's why you'll get the surface antibody if you have a vaccine, but you won't get the core antibody being produced, versus if you were actually infected, your body would first produce the core antibody and then produce the surface antibody, kind of like working upwards. So that's a bit of like background information. We'll just have a look at this table now. So in the first situation, you don't have any antigens, meaning that you are currently not infected. You don't have any antibodies, not the core one or the surface one, which means you have not been you have not been infected in the past. You are currently not infected, but you are also not vaccinated, which means you are susceptible to being infected in the future. Next one, we have a negative antigen, which means you are currently not infected. Our core antibody and surface antibody here are both positive, which means that you don't have the infection at the moment. However, you did have it in the past. And this is immunity due to natural infection because both your core and your surface antibody are positive. Next up, you've got your antigen being negative, your core antibody being negative, but your surface antibody being positive. And that basically means you had a vaccination. The vaccination has caused you to produce a surface antibody because that's kind of the stronger one in comparison to the core. That's why you haven't produced any core antibodies because you've already got the surface ones, which are stronger. Don't know if that's like explained well, but essentially if you have the stronger antibody, you won't need the weaker one, is pretty much the reasoning behind it. Next one, so you've got your surface antigen, which means you are infected. IgM here is positive, which means you are acutely infected. The core antibody is positive, meaning you are currently producing antibodies to try and overcome the infection. However, the surface antibody is not positive just yet, meaning your body's kind of like getting onto it, but hasn't yet produced any surface antibodies. Next one, yes, so currently infected because you have the antigen. The core is positive. IgM is negative, which means it's not an acute issue anymore. It's a chronic issue, which is why this person is chronically infected. And here the surface antibody is also negative because they haven't overcome it yet. Last one, this is a bit strange. The surface antibody is negative, so they're not currently infected. They're not completely immune either because the surface antibody is negative, but they have got the core antibody. So the interpretation is a bit unclear. A couple of possibilities. So it can either be like a resolved infection, but they haven't actually become immune to it because they don't have that surface antibody that's been produced yet. Another one is you could have a false positive. So this is actually meant to be negative. Hence, this person would actually be falling in the first category. Next, you can have a low-level chronic infection in which the antigen's just not being like produced, not being picked up, or resolving acute infection as well. Okay, hopefully that wasn't too confusing. If it's confusing, yeah, chuck me a message and then I'll hopefully explain it again. But yeah, hopefully these three will make a bit, yeah, if you understand what the core antibody and surface antibody are, this table will make a bit more sense. Okay, last two slides, I believe. Yes, gallstones. So basically first, before we get to gallstones, just terminology wise, cholecystitis refers to the inflammation of the gallbladder. Cholelithiasis refers to gallstones within the gallbladder. Choledocholithiasis is gallstones, but in the common bile duct over here. And ascending cholangitis means you have a kind of like blockage that's causing backflow of bile, which is dangerous because it can go on to cause sepsis, which is just bacteria in the bloodstream, which can go to places it's not meant to go to. And ascending cholangitis, the way we kind of diagnose it, or like a way of clinically diagnosing it, I guess, is via Charcot's triad. Three things. So you've got your jaundice, fever, right upper quadrant pain. If you have those three, that is usually indicative of ascending cholangitis. In terms of where can gallstones often be lodged, so common bile duct is the most common place for gallstones to be found. Apart from that, you've got your hepato-pancreatic duct and also your Hartmann's pouch as well. For gallstones, you usually have two types. You've got the cholesterol ones. This is like, yeah, pretty much 75 to 90% of gallstones are cholesterol stones, and these don't show up on x-rays. Bilirubin stones, they contain calcium, so they do show up, but because majority of our gallstones are cholesterol stones, the way we diagnose it is using an ultrasound. So the first thing to do would be ultrasounds. You would also go on to do your LFTs as well. That's just to double check that this is a cholestatic issue instead of a like a liver issue. In terms of risk factors, once again, very, very buzzwordy, 5 Fs. So female, 40, fair, fertile, fat. So if you have a stem with, I don't know, like a 40-year-old female complaining of right upper quadrant pain, you can see that she's a bit jaundiced, and she's also like quite fat, And she says, oh yeah, this pain has been coming on, especially when I'm eating fatty meals. Very, very buzzwordy, probably going to be gallstones or some kind of like, wow, what's it called? One of these few. Yeah, pretty much just remember these like 5 risk factors for gallstones. All right, that's pretty much it from me. So that's all of GIT physiology. Hopefully I haven't gone on for too long. We will see once this recording gets uploaded. But yes, if you have any questions, feel free to send me a message or basically just chuck a question on Curious Cat. We will be checking that as well. But in the meantime, enjoy the rest of GIT. Hopefully you guys will find it quite fun, and see you guys in the next video.